avascular transparent structure. It is steeper in the center, less steep in the periphery, and that is a kind of the anatomic natural orientation of the cornea that's called a prolate cornea. If you've got a situation like after LASIK, they're going to be flatter in the center, more steep in the periphery, and that's termed an oblate cornea. So these are terms you might see. The cornea has very, very high density of nerve endings, and that's why if there's anything disturbing the cornea, it is very, very painful. So here is the pathophys cross-section. I've got epithelium, stroma, Descemet's membrane, endothelium. The epithelium is composed of stratified squamous epithelial cells, about 4 to 5 cell layers thick, and there are tight junctions between the epithelial cells to prevent fluid from getting in. And then that sits on a basement membrane, which is not labeled. The other non-labeled thing on here is below basement membrane and before like the stroma, there's an acellular layer that is termed Bowman's layer, or sometimes maybe called Bowman's membrane. So this area is actually not a true membrane, it's simply acellular, but it's a nice like demarcation kind of underneath the epithelial basement membrane and stroma. Stroma comprises the main thickness of the cornea. It's composed primarily of keratocytes, and they are arranged in a very specific pattern so that it can maintain transparency. The other factor, very important factor that maintains transparency of the cornea is having a water content of the cornea that's just at like 78% water content. And that is maintained by both the tight junctions in the epithelium as well as endothelium and the endothelial pump within the endothelial cells. So that's that bottom kind of most posterior layer is endothelium, and that rests on, the endothelial cells rest on Descemet's membrane, and Descemet's membrane is a true basement membrane. Then you also have the tear film, which also has layers as well, 3 main layers, lipid layer, aqueous layer, and mucin layer. And all 3 components of this are important for maintaining a healthy tear film. So the top layer is the lipid layer, so this is produced by the meibomian glands. The aqueous layer is the main portion there, produced by the main lacrimal gland. There are also some other accessory lacrimal glands within the tarsal conjunctiva of Krause and Wolfring. Sometimes you might get asked about these. Krause is in the conjunctiva fornices, Wolfring is in the tarsal conjunctiva. I remember this, just a silly little thing that I used since residency to remember this was Krause is like K's in the corner, the conjunctiva fornices are in the corner of the conjunctiva. That's how I remember it. Mucin layer is the very bottom layer, and that's responsible for actually sticking the whole tear film to the ocular surface. And these are produced by goblet cells, which are also within the conjunctiva. There are some microvilli of the epithelium that helps also adhere the whole tear film together. So going over some, any questions on tear film or cellular anatomy? Okay, so we're going to move on to slit lamp techniques. So I've listed a few here. Probably the 2 most common ones that you'll use are going to be diffuse illumination and slit lamp illumination. I usually like to start off with diffuse illumination, which is just low mag, kind of a broad beam, just to kind of get a kind of a unmagnified view or less magnified view of the whole eye, just to see what's going on. So here, your kind of attention is drawn through to this, whatever's going on here. And then when you have the beam down to a slit, and then you can manipulate the slit lamp, so you're going, looking at all the different depths of the cornea, then you can further assess everything, including whatever details you want to assess more fully. Retroillumination is another maybe common technique that's used. This is where you shine the light like directly in the pupil, and then you see the light, red reflex bounce back. This is really nice for looking at iris transillumination defects, seeing whether or not you have a patent LPI, peripheral iridotomy. This is an example here of a patient with very diffuse transillumination defects. So these are things that you may not be able to see quite well with either diffuse or slit lamp illumination. You can also see some subtle lens and corneal findings with retroillumination as well. These two other ones are not really used commonly, but I'll just mention specular reflection is used to mainly look at kind of fine endothelial subtle abnormalities. And so you take your slit lamp beam at like a 60-degree angle, and you have to like superimpose the like light bulb reflex that you're usually supposed to ignore. So you superimpose that on like your slit beam, and then kind of focus in a little bit more to see, kind of highlight little things around the endothelial cells. Sclerotic scatter is one where you can shine a really bright light at an angle onto the limbus, and then the light kind of goes across the whole cornea, and it can highlight maybe subtle findings on the cornea. So this is highlighting the fact that there's a scar on the cornea. So sclerotic scatter. Questions there? Yeah.
For sclerotic scatter, what angle do you put your beam at?
It's just at any angle, just so not right on, so any angle right onto the limbus. Corneal stains, by far the most common one that's used and available is going to be fluorescein. It comes in solutions or strips. This is going to stain basement membrane, so this is highlighting some punctate epithelial erosions there. Rose bengal and lissamine green are not so common. I don't even know if we have any of this in Moran anymore, but both of these stains stain devitalized cells. So it's a little bit different than fluorescein. It does highlight defects in the epithelium really well. So any defects, like even punctate staining on the conjunctiva, can stain really well with both rose bengal and lissamine green. The thing about rose bengal is that I don't think I've even ever seen it used, but it stings a lot, even with topical anesthetic. Lissamine green doesn't really sting. I don't know if we even know if we have it around, but there might be a few. You might find a few strips of this floating around in the drawers, but it highlights everything really dark green really nicely. Other things you should know about when you're first examining patients, especially for inpatient consults, ED consults, always ask the patient or assess the patient for soft contact lenses. So you want to remove it prior to putting in fluorescein, only because fluorescein is going to permanently dye the contact lens. So the contact lens will still be usable. It's just going to be permanently dyed that fluorescein yellow color. Also, keeping track of your whatever tetracrine or fluorescein solutions that you have on hand, just because, especially more in the ER setting, if you've got a patient with a painful eye from like an ulcer or from a corneal abrasion, and you're putting in the tetracrine and their pain magically goes away, and you kind of leave that bottle out, they just might take it and start using it and cause another major, worse problem down the road with tetracrine abuse where that defect is not going to heal. Anyone with corneal abrasions, red eyes, you might consider flipping their upper lids to see if there's anything hiding underneath the upper tarsal conjunctiva to be causing their complaint. So sometimes you're surprised by what you find under there. You can find things that are causing corneal abrasions. Other acute conditions that you can find in the anterior segments, so conjunctivitis and the whole list there. So we're going to go through everything. So conjunctivitis, there are three main categories: bacterial, viral, and allergic. A lot of times it's the history that'll kind of help point you in one direction or another. So with bacterial conjunctivitis, you'll see like really purulent discharge, usually just in one eye, but it could be in both. With viral, the history usually is they've got some sick contacts, or with like upper respiratory infection, or the patient themselves has a cold. Then they get like a red eye in one eye, and then a couple days later goes in the other eye. So that's pretty classic for viral conjunctivitis. With allergic conjunctivitis, the main symptom is going to be itching. So their discharge is going to be more maybe teary. It's not going to be purulent, but it's really going to be itching, and it's usually in both eyes. And then on slit lamp exam, you can look at the tarsal conjunctiva to look at the reaction on the tarsal conjunctiva, and sometimes that can help you distinguish with different types of conjunctivitis. So the main two reactions are follicles and papillae. Follicles are like clusters of lymphocytes with not really much of a vascular reaction. And papillae are very vascular, and there's like kind of a middle capillary within the middle of each papillae. Papillae are seen with allergic conjunctivitis, follicles more with viral. Sometimes you'll get a mixture, and it's maybe hard to tell, so it's not always quite so distinct. So don't feel bad if you're looking and like, I'm not sure what exactly it is. A lot of times there's a little bit of a mixture, but if you do see like clear follicles or clear papillae, then it makes the diagnosis easier. Here's an example of GPC, giant papillary conjunctivitis, which can be seen with contact lenses. So that's another reason to flip upper lids, because you'll see this more in the upper tarsal than the lower. Conjunctivitis treatment, if it's really purulent, you want to culture it. It could be something like gonorrhea or chlamydia. And so hyperpurulent discharge is pathognomic for gonorrhea conjunctivitis. And what does hyperpurulent mean? It means that like as you're like clearing the eye with say like a cotton tip to just see, and you like get them to the slit lamp to look, like their eyes are already full of pus already. So it's like within seconds, it just keeps filling. So that's what hyperpurulent is. So it's something. It's a lot more than just a little bit of purulence all day. It's going to be like accumulating really rapidly. So if you are suspicious of gonorrhea, I'm going to start topical fluoroquinolones, give them systemic treatment as well. They are at high risk for corneal perforation, so they do need very close follow-up. If it is in a patient that you're not sure if they're going to follow up, this is the type of patient that should be admitted to the hospital. Acute viral conjunctivitis is going to be way more common, and what I've started doing in patients that I suspect have viral conjunctivitis is putting in some topical betadine at the time of exam, which is readily available in my clinic, maybe not so readily available in the ER, but that's something that I've started doing. And then the treatment for that is going to be just more symptomatic with artificial tears, making sure they're not wiping their eyes, making sure they're not touching anything else, trying not to spread it to anybody else. Allergic conjunctivitis treatment is going to be typically topical allergy drops, sometimes steroids. If there is some GPC, you also want to stop their contact lenses, obviously. Any questions there? Yeah.
For gonorrhea, and let's say it's a reliable patient and everything like that, and cornea is not perforating, but you see an epi defect in that setting, would you admit them then, or I guess when do you feel?
I mean, I think if it's someone who's not going to follow up,
okay.
it's like that type of patient should be probably seen daily for a little bit before kind of extending things out. Yeah, well, if there's an epi defect, then they are at higher risk for perforation, yeah.
Okay, I maybe I'm misremembering, but if there was any sort of like corneal involvement, I remember reading that they need IV ceftriaxone instead of IM, but I don't know.
Yeah, it depends on the severity. Yeah, I mean, if you've got like a huge ulcer, then yeah, you probably should, and it's gonorrhea, then yeah.
Oh yeah, just with that then, if you're the call resident on Friday and you get blessed with one of these, it's probably not a terrible line. Like that may be on the line of possibly being admitted, because they're not gonna, well,
I guess, I mean, they'd have to be seen daily, so it depends on the patient. Like if they can come in and they're motivated and you trust them and they can put in their drops, and yeah, they could be seen, I guess, at the Moran, like kind of an outpatient call basis. But if there's any sort of question or you're not sure they're going to be able to put their drops in, then they should be admitted, yeah. Oh, yeah.
The viral conjunctivitis, what's the rationale for the betadine?
I think it just kills off whatever virus is there, and so it might shorten the course of the conjunctivitis a bit. Yeah. Actually, I think there was a study, like someone was trying to come up with an eye drop that was like betadine with steroid drop. I think it was like a pharmaceutical company trying to develop it, but I don't think it met criteria for FDA approval, so it hasn't passed.
And do you flush it out after?
No, I just leave it in. Yeah. After, well, I put in like topical anesthetic and then the betadine, and then I just leave it in. Okay, so moving on. Episcleritis, you might see this on call. I mean, people usually aren't coming in like really acutely for this, but you might see it. This is a benign, typically transient inflammation of the ocular surface and episclera. Usually the history is minimal or no pain, so this is not something super painful. This is the one that blanches. If you put in phenylephrine, the redness will go away pretty quickly. Typically, I don't work these up like with any blood work, but if it is recurrent, then I will work it up. There are some systemic associations like autoimmune collagen vascular disease, but also zoster, gout, and syphilis are also further down on the list. Typically, it's self-limited. This is one that even if you don't do anything, it will eventually resolve on its own. But if you wanted to maybe get it to go away faster, you could use higher dose PO NSAIDs or topical NSAIDs or topical steroids. Now, scleritis is going to be typically more painful. This is going to be very tender, very painful, very red. This does not blanch with phenylephrine or neosynephrine. There are a few types. There's non-necrotizing, which is this top picture there. We've got necrotizing without inflammation, which is actually painless, so it's kind of an unusual form of scleritis. And then necrotizing with inflammation, which has all the kind of really bad scleral thinning that you see down here. Scleritis has a high association with systemic, typically autoimmune disease. So systemic associations are things like RA, lupus, ankylosing spondylitis, Crohn's, psoriasis, vasculitis, syphilis and TB also. So scleritis is one that you always want to work up. So episcleritis, typically don't have to work up, but scleritis, if someone has what you think is scleritis, always have to work it up with checking for like ANA rheumatoid factor or anti-CCP. You can check on HLA-B27, checking for TB, syphilis, the ANCAs. If the labs are negative, you might consider repeat testing in 1 year. So with non-necrotizing scleritis, this is the least severe form. You might read about what's called a violaceous hue, which is this kind of really red, maybe purplish color. There is a 50% association with systemic disease, and 50% of the time these can be bilateral. Scleromalacia perforans, this is necrotizing scleritis without inflammation, only because the eye isn't red. So it's typically a painless white quiet eye with some thin sclera, so you can see the areas of thin sclera here. Typically seen in the elderly, this is typically bilateral. This is usually like 50% of the time from RA, rheumatoid arthritis. Thankfully, scleral rupture is rare, so this is not something that I'm going to be surgically treating, but if I do see this, I do want to make sure that you send the patient back to their rheumatologist to treat their RA more effectively. Then there's necrotizing scleritis with inflammation. This is typically very painful. It's typically bilateral, and this is going to be the most destructive type of scleritis, associated typically with systemic vasculitis, such as what was termed Wegener's, which is now called granulomatosis with polyangiitis. There's actually a high mortality rate if you see this because of this association with vasculitis. The mortality rate is 20% at 5 years. So this is obviously someone who's going to need to be sent urgently to see rheumatology for systemic immunosuppression. So questions there on episcleritis and scleritis? Okay. Next, this is going to be super common, contact lens abuse. Typically, the history is going to be they're wearing their contact lenses all day, they're sleeping in their lenses, or not cleaning them. Typically bilateral, and you'll see conjunctival injection, you'll see a vascular pannus, so that's a sign that they're just wearing their contact lenses a lot. Punctate staining, you might see these little tiny fine subepithelial opacities. So the treatment is going to be stopping their contact lenses until all their symptoms resolve. Typically just do artificial tears. You might consider a mild steroid drop. I like to only do it if someone kind kind of confirms that they're reliable, like they come to their appointments and they're not going to just take steroids and never come back again. So I don't usually, I'll try and get a sense, but I don't usually prescribe steroids at the first onset unless I think they're going to be reliable. Corneal ulcers. So again, most frequent risk factor for these are going to be contact lens use, but there's all kinds of other high-risk factors with ulcers, any previous eye surgery, history of trauma, if there is severe dry eye, ocular surface disease, if the patient is immunosuppressed. And you do want to get from their history, like how much pain they're having, how much how long this has been going on, if they've been on any other eye drops or other previous treatment. Bacteria etiologies are going to be the most common. This typically has a fairly quick onset. But then other causes include HSV, fungal, parasitic. So when you're assessing a patient with a corneal ulcer, you do want to note its exact location, the shape of it. Is it round? Is it like stellate? Is it dendritic? The size of it, so you want to measure it. The depth, is it superficial? Is it more endothelial? Is it like panstromal? The density and consistency, meaning is it like really dense and opaque? Is it kind of thin? You also want to look at the associated inflammatory response around the ulcer. So like this, for example, this ulcer right here, like I would probably describe this as a 1 millimeter round ulcer. I don't know off this 2D image if it's, panstromal or what depth it's at, but I kind of noticed that there's some haziness around the ulcer. So this is what I'm talking about, an inflammatory response. So I'll note that there's some haze, maybe 1 to 2 plus haze around this ulcer. And it's important because once there's less of an inflammatory response, it's getting better. So you'll see, I might see the same sized opacity here, but then when there's less inflammation, this haziness around it will become clear. Okay, questions there on history. Okay, so when do you culture? So whenever it's large, and large can be, I guess, it's kind of subjective, but I'd probably say anything over 2 millimeters would be large. Anything vision threatening, meaning close to the visual axis. If there is a hypopion, that would be considered severe. If they're post-op, especially from like a corneal transplant, I'd definitely be more apt to culture these. So how do you culture? So traditionally, there is something called a Kimura spatula, which is like a thin metal spatula that was used, which you don't really use anymore. You can use calcium alginate swabs. Next slide, I'll have what we currently use, but basically swab the ulcer, traditionally putting onto different culture plates, like gram stain. I think these things still get asked on OCAPs, maybe, yeah. So blood augurs for aerobic bacteria, chocolate agar for Neisseria haemophilus, Sabroids agar for fungus, thioglycoid broth for anaerobic bacteria. Here at Moran we have, for acanthamoeba, we have something called Page's media that I think it comes in its own little thing, but there's not a swab with it, so you have to get a separate swab for it. We also have viral cultures. I think those are little pink tubes for HSV and zoster. But what we usually do, unless you're swabbing for like acanthamoeba or virus, pretty much everything else is on something called an e-swab, which maybe some of you are familiar with. So it's super easy. What the e-swab is it comes in a tube like this. There's a kind of a swab that comes with it, and it's a very specialized nylon tip swab that allows for improved sample collection. So when you look at it under a microscope, it's got all kinds of tiny little appendages of this swab that come out, and so it really tries to get as much sample as you can. So then when you culture, you put it in this little medium tube, specific medium. That's all you have to do. You don't have to get plates. It's really nice. You just send that to the lab. What the lab will do is the lab then aliquots the sample into the different plates and whatever it has to do to culture. This has been found to be non-inferior to traditional culture methods. And you can run aerobic, anaerobic, and fungal cultures through this, but just not acanthamoeba or viral. So just know you just have to do separate swabs if you're suspecting that.
Dr. Lim,
Yes.
we asked lab last year, and
Yeah.
at least
Something
I've
different
been, say that again.
Oh, is it something different now? I feel like.
Oh, yeah, so we've been doing HSV and VZV too.
Oh,
I've
really?
had like positive, results.
Oh, just with the e-swab?
that, Yeah.
Really? Okay.
Just sent like all 5 together.
Okay. Acanthamoeba they can do? Okay. Yeah. Okay. Well, that's good to know. All right.
Gonorrhea, chlamydia is on the aptoma.
Yeah.
It's like those separate
It's on the what?
on the aptoma swab,
Oh, yeah, that's a separate swab.
GCCT.
Yes.
They have those. I don't know about PCHER, but they do in the UVR. So.
Okay, good to know. All right. So initial treatment will depend on the severity. So if it's fairly small and peripheral, I might just do Moxie 4 times a day. You can increase it to Q1 hour. If something is more kind of larger and more vision threatening, you want to start them on fortified antibiotics. They can be compounded here at our pharmacy or inpatient pharmacy. I typically do vancomycin and tobramycin. It's already kind of, you can choose these options in Epic, so you don't have to really think about your dosages, but that's what they are. Doing that Q 1 to 2 hours. You can consider a topical cycloplegic agent. And then again, same with like what we were talking about with like, if you suspect like gonorrhea, conjunctivitis, if you have a severe ulcer and you're really not sure if they're gonna be following up or putting in their drops, you could consider admitting. I know there are some programs that like admit a bunch of their ulcers, which we don't typically do. Like, I think admitting someone for an ulcer is pretty uncommon, but it probably happens a few times a year. We're admitting someone for an ulcer. Moving on to herpes simplex, keratitis. Again, very common. The symptoms of this are going to be very kind of non-specific. So their eye's going to be red, it might be blurry, there's going to be some irritation, but there could be severe pain. So you can't really tell based on history that something's going to be HSV. They will have diminished corneal sensation. So this is something that if you're suspecting, you do want to check it prior to putting in anesthetic. And I take like a cotton swab and kind of just like string it out and then just kind of touch that little strung out cotton tip to their corneas and just ask them, do they feel one side more than the other? Types are epithelia, which is going to be your classic dendrite, which has terminal end bulbs in the end. Stromal keratitis is actually probably the most common form, which is going to be it's going to be a non-specific haziness of their stroma, and if it's been around for a while, there'll be some NV. The disciform type is going to be more posterior stroma or endothelium, so it can be termed endotheliitis. With disciform herpes simplex keratitis, you'll see some KP surrounding it. So the treatment of epithelial disease, they actually sometimes can resolve spontaneously, but I'll never kind of send someone out without treatment. But the treatment does definitely shorten the disease course. Topical trifluridine is something that we don't really use anymore, but you might read about it. Nowadays, I usually go just oral with either acyclovir or Valtrex. You can use topical Zergan gel, which is topical ganciclovir. It's just not well covered by some insurances, so I don't move to this unless someone's not responding to oral. So the dose for your acyclovir is traditionally it's going to be 400 milligrams 5 times a day. I'll kind of just, I know the 800 milligram BID is not quite 400 milligram 5 times a day, but just to simplify it for someone, I might just do 800 milligrams BID or Valtrex, 1 gram BID. You don't do steroids, topical steroids for epithelial HSV disease. Some people do epithelial debridement where they'll remove the dendrite. That's not something that I've done, but some people think that shortens the course too. There was a landmark study several years ago called the HEAD study or herpes eye disease study, which was looking at the efficacy of topical steroids with what was topical trifluridine So there was topical steroids in treating HSV stromal keratitis along with prophylactic trifluridine, oral acyclovir with stromal keratitis in patients already on steroids and trifluridine. And they also looked at oral acyclovir with HSV iridocyclitis. So they did find that topical steroids given with a topical prophylactic dose of trifluridine did reduce the progression and shorten the duration of stromal keratitis. Adding oral acyclovir when someone's already on a topical antiviral and steroid did not show any additional benefit. However, there was maybe a benefit for oral acyclovir in HSV iridocyclitis. So for prevention of recurrent inflammatory disease, the dosages go down. So acyclovir for the prophylactic dose is 400 BID. Again, the treatment dose was 400 five times a day, or I do 800 BID. And then Valtrex is 1,000 once a day. It's prophylactic dose. Late complications of HSV keratitis are going to be a neurotrophic cornea. That just means a cornea that doesn't have great sensation. So the patient is going to have permanent dry eye. In some severe cases, there may be epithelial defects that aren't really healing. You can get corneal scarring, neovascularization. There can be recurrent inflammation and corneal thinning. The cousin to herpes simplex is going to be herpes zoster. So this is reactivation of the zoster virus, and there is a high likelihood of ophthalmic involvement when it involves the tip of the nose, which is Hutchinson's sign. And the pathophys of that is because the tip of the nose means that the nasociliary nerve is involved, and the nasociliary nerve does innervate many structures in the eye. And so this is a very strong predictor of ocular inflammation. So manifestations, I'd say, and I don't know if it's more common in the elderly anymore. We see plenty of patients now who are younger having zoster. There's a wide range of ocular involvement and severity that can be acute, chronic, or relapsing. The dendrites seen with zoster are not as kind of nicely structured as a simplex dendrite. So these are, they kind of look like this. So it's not like a nice branching thing. There's no terminal end bulbs. I'm terming this a stuck-on appearance, meaning it kind of looks elevated, whereas a simplex dendrite kind of looks more excavated. So simplex is kind of like, it's sitting like further down, kind of below the level of the surrounding epithelium, whereas with a pseudodendrite with zoster is going to be kind of stuck on. You can see stromal keratitis, and like HSV, there's going to be decreased corneal sensation. I'll start acyclovir kind of at a higher dose, 800 milligrams, 4 to 5 times a day, or Valtrex TID, 1 gram TID for 10 days. And then there may be a role for a reduced dose long-term prophylactic, which I'll go over. There was a study that the results came out recently on that. And then definitely, I always do topical steroids. So even with pseudodendritic zoster disease, I will start topical steroids for that, whereas with simplex, we typically do not. Typically, though, patients do need to be on a long taper of steroid eye drops or even be on them chronically to prevent recurrences. Late complications are similar as HSV, except that they can get very severe post-herpetic neuralgia. And so that's treated with kind of things like gabapentin, tricyclic antidepressants. So that's someone I might send someone back to primary care or pain management for. But otherwise, the complications are the same as HSV, neurotrophic keratitis, corneal scarring, neovascularization, recurrent inflammation, and corneal thinning. And in some cases, it can be severe. So the Z study was a recent study that finally completed, and they announced their results in the past year. So this was a big multi-center study looking at zoster patients with active disease within the previous year. And these patients were randomized to either Valtrex 1,000 milligrams a day, that's the prophylactic dose, for 12 months versus a placebo. And they followed these patients up for 18 months. So their results showed that there was a treatment benefit in reducing new or worsening corneal complications at 18 months with a 27% reduction. Patients with zoster in the prior 6 months had a treatment benefit at 12 and 18 months. And there was also a decrease in neuropathic pain in the treatment group at 18 months. So it does show that there's benefit for long-term Valtrex for 12 months. We don't know if there's any additional benefit for Valtrex even longer. I'll keep it on for longer, definitely in patients who had maybe very severe disease initially, or if they've had like multiple recurrences, like multiple recurrent inflammatory episodes. I kind of keep them on prophylactic dose forever. Questions on corneal infections?
For unspecified herpetic presentation or HSV, if we do see uveitis and also epithelial involvement, like for your practice pattern, do you usually wait for that to close, or would you just put them on?
Yeah, that's.
That,
Yeah, I
answer that at one time.
probably would start a little bit of a steroid just for the uveitic component, and maybe once the dendrite or the epithelium heals, then like really bump up their steroids. That's probably what I would do. I don't think I've seen that too commonly though, but I'm sure it does happen. On call. Okay. Yeah, but usually usually the HSV that I see is not the classic dendrite. Like you might see an epidefect. Yeah, you're right. You might see an epidefect with stromal involvement, and I still start steroids in those cases, yeah. But if it's like the classic dendrite, I usually don't. Yeah.
Sorry if I missed, what's the prophylactic dosing of Valtrex in this case?
Yeah, so Valtrex 1 gram once a day.
Once a day.
Yeah. Okay. All right, we're gonna get into trauma. So corneal abrasions, very commonly seen. Treatment, I usually do a fluoroquinolone 4 times a day. Something that I've seen residents and even some attendings doing is like, if it's like a large corneal abrasion, they're on like Moxie Q 1 hour, and if it's small, it's 4 times a day or 3 times a day. I don't think there should be like, if there's not an infiltrate, like I don't think you need to be on like Moxie Q 1 hour if it's like, even if it's a giant corneal abrasion. So if it's just a corneal abrasion, Moxie 3 to 4 times a day is just fine. So you don't have to go overboard. Now that's different if you think it's an ulcer, then yes, please do it Q 1 hour. But otherwise, no. You can consider a topical cycloplegic agent. You could consider a bandage contact lens or a pressure patch. You do want to follow them, monitor them to make sure they don't develop infection. If there's not like a reason for it that you're seeing, the abrasion, like there wasn't like a history of, oh yeah, like someone poked me in the eye or something, and there's not like major exposure, like meaning like say someone with like a lot of black ophthalmos to cause a corneal abrasion. Like if you don't know what the reason is, like invert their upper lid and look for a foreign body. So corneal foreign bodies, also very common. Metal is by far the most common object that you'll see in the cornea. If it's superficial, you can remove it with a 27 or 30 gauge needle at the slit lamp. I don't usually burr, but some people do burr out the rust ring. I usually just use the same needle for taking out rust rings. And then afterwards, it's kind of like an abrasion, but it's pretty common to have some surrounding, like you'll see like a white kind of infiltrate, which you kind of see here around the foreign body. So I'll sometimes like add a steroid in addition to antibiotic as well. If it's really deep, don't pursue it. And then counsel the patient on eye protection. And then they do need follow-up as an outpatient afterwards to make sure they're healing. Corneal lacerations. So you want to determine, is it full thickness or is it partial? So with the Seidel test with fluorescein. This is obviously open that you can see, but if it's subtle, sometimes you do need a Seidel to see if it is full thickness or not. The other sign is looking at the anterior chamber depth and comparing that with the other eye. So if you think you see a shallow AC and maybe you do a Seidel test and you're, hey, maybe it's Seidel negative, but maybe you think that there was some sort of full thickness situation, you can look at the other eye. And so if the other eye is like way deeper and you've got kind of a much shallower AC, you can kind of surmise that maybe this laceration was full thickness and now it's kind of self-sealed at the moment. Peaking of the pupil and iris are going to be very obvious signs of a full thickness laceration. If it's partial thickness, you can, and if there's foreign bodies, you want to get those out. They do need to go to the OR for repair, obviously, if it's full thickness, or you might consider also for a deep partial thickness laceration. Place a shield on the eye. You might consider some IV antibiotics and make sure they're NPO for their surgery. Questions here? No? Okay. Oh, yeah.
With the big corneal abrasions, like when do you usually decide to do a BCL or not?
That's a good question. If it's large, I might consider it, but I won't do it if it was from like, if they had like a contact, if it's from like a contact lens, like they're like, oh yeah, like my contact lens was like so hard to take out, and I finally took it out, and now my it's pain, and you look and you see like this, like because they just freshly had like another contact lens in, like probably wouldn't do like another BCL. But the other time I won't do a BCL is if it was like some, like, let's say plant matter or something that was along those lines that caused a corneal abrasion. But it is pretty painful. And again, if someone is, you think, very reliable and is going to follow up, then you could put a BCL in. If you're not sure, it's totally fine to just maybe start the fluoroquinolone 4 times a day. You could do an ointment, follow up the next day, and if they're seeing me, I can kind of make a judgment call. And I usually, by that point, I'm putting in a BCL, unless if I think like, if I see like a little bit of an infiltrate, I'm not sure if there's something is going to be like infectious, then I usually try not to. Yeah.
What's the function of cycloplegic then for the corneal abrasion?
Oh yeah, so the function of cycloplegic, good question, is for taking the edge off the pain. So if you like freeze their pupil, like it kind of makes them like, it's a little bit less painful. It's not going to take away all of it, but it does help a little bit. Any questions? Yeah.
For the rust streak specifically, I know that we get called like a good bit about that. Like the ED will kind of like flick something off and then
Yeah.
there will be a rust streak.
Yep.
How aggressive or not aggressive do you think we should be?
I wouldn't be super aggressive. I would try to take it out. Like when I'm taking it out, I'm using like a 30 gauge needle and kind of gently removing. But if there's like, oftentimes there's a little tiny speck kind of deeper or a couple specks, like I'll leave them. Like if it's not really coming out easily, I'll leave them. And then it's fine. It just kind of scars. It's fine. I just don't want to leave like the giant rust ring in their eye. But yeah, I try, but not super aggressive. Yeah. Okay. All right. All right, so some special cases that you'll see in the burn unit. So starting off with thermal and chemical burns. So with thermal burns, there can be various agents that can cause a thermal burn: flames, blast injury, scalding liquids. The globe usually is not involved because you got a nice blink reflex, so usually people have more severe eyelid involvement. And so that's usually what you'll see. Obviously, you still can see bad thermal burns on the cornea, but usually not as much. Chemical burns definitely can affect the ocular surface more frequently. This can come from a variety of agents again. Alkali agents usually penetrate deeper than acidic. So what acids do is the acids cause coagulation necrosis of the tissue that it touches, and that necrosis prevents further progression of that acid deeper in the eye. Whereas alkali agents will cause saponification of fatty acids, which cause kind of more cellular disruption, and that allows the chemical to go deeper. And so that's why we typically see more severe involvement with alkali agents rather than acid, although there are a few very strong acids that can be just as bad as alkali agents as well. Acutely, you might see someone like this who is, will need, hopefully they already got irrigated, but if not, you definitely need to irrigate. Check the pH. I've heard of pH strips being faulty, meaning like they're always reading like a really high pH. So if you're not sure, if you're like irrigating and you're checking the pH and it's like, man, this is not going down, like check your own eye with the pH strip. And assuming you have normal pH of your tears, like whatever color it is on your tears is going to be normal. So I've just heard of issues where for some reason the pH strips are not accurate, but I haven't heard that lately. So I don't know if anyone's experienced that lately or checked pH with ever, but that's just something that I've heard of. Do a complete eye exam as best you can. Look at their eyelids, look for edema like ophthalmos, lash loss. Check the Bell's reflex to see if there's any lag ophthalmos. So this is a patient who, just sitting up and looking straight ahead, and then you ask them to close their eyes, and you see a lot of lag ophthalmos, but this patient has a really good Bell's reflex. So the Bell's reflex is just the cornea kind of turning up, and the cornea is completely hidden underneath the eyelids when he tries to close his eyes. So this is a good thing. If someone tries to close their eye and you still see a big part of the cornea, that patient's going to be at a lot higher risk for exposure. Look for corneal epithelial defects, foreign bodies, remove any foreign bodies that you see, assess for opacities. You want to note the amount of limbal ischemia. So if there is globe involvement, there's something called limbal ischemia, which is necrosis or loss of the limbal stem cells. So here are two pictures. Here is one where you see this white patch here, and here's one that it's completely red. And so the one with limbal ischemia is going to have a much poorer prognosis. So even though this looks really red and beefy and angry, that means that there's great vasculature here, whereas there's not going to be great vasculature and great any limbal stem cells in this area. So this patient is going to have a poorer prognosis later on. Late complications, there are lots of them. You can have, again, along with limbal stem cell deficiency, patient can have difficulty healing their corneal epithelial defects. So they might have persistent defects that can lead to corneal thinning and even perforation. If there is corneal neovascularization kind of associated with stem cell deficiency, that could be very severe and visually significant. And that can also lead to scarring. There can be scarring of the conjunctiva, some blepharon of the conjunctiva. On the eyelids, you can get ectropia and entropia, trichiasis, and lag ophthalmos. So treatment, so I do vitamin C. You can also consider doxycycline if there's any corneal involvement. So doxycycline does have some anti-inflammatory effects. For the eyelids, lubricating or erythromycin ointment. You can consider a topical antibiotic if there is an epithelial defect, or just erythromycin ointment. If there's steroids, that can be used to reduce inflammation. You can consider soft bandage contact lens, maybe even amniotic membrane in severe cases if they're not healing. If there is some lag ophthalmos, you want to do very aggressive lubrication like ointment Q1 hour, have them wear moisture chamber goggles while they're inpatient, consult oculoplastics. Oftentimes, they're not going to want to go in and be aggressive with eyelid repair, because if they are aggressive with eyelid repair, oftentimes that lag ophthalmos comes back like really quickly. So what oculoplastics usually likes to do is they like to have them wait a while, like until they're kind of not really inflamed anymore, and then they'll go into repair. So in the meantime, you're gonna have to deal with the lag ophthalmos. And so we actually have a way of doing scleral lenses as an inpatient for helping with persistent epidefects from exposure keratopathy. So if you have a patient with exposure with recurrent or non-healing epidefects, maybe getting to some corneal thinning, you've tried the ointment, you've tried moisture chamber goggles, maybe some soft bandage contact lenses, and they're just not healing, this is a great option. So there's much less risk of infection compared to bandage lenses. I think I don't know if we have a protocol for the residents on box, but scleral lenses, if you've maybe heard of them or not heard of them, typically they're used outpatient, and typically they're for patients with like severe irregular astigmatism, like keratoconus patients, post-PK patients. I also use them for patients with severe dry eye disease. They benefit from a scleral lens. I don't describe it. So basically, it's a lens that you fill up typically as an outpatient with sterile saline. And then they put it in their eye, and the saline is bathing their eye all day. And then the contact lens also helps with any astigmatism, and it helps kind of protect the cornea as well. And that's why it helps with dry eye. For inpatient use, you're not going to be able to put a scleral lens in a patient laying down just because the saline is going to dump out everywhere. So the protocol is you get a scleral lens, and again, this is not a non-fitted. So scleral lens is also usually customized fits. These are not customized fits. Like you just grab like any scleral lens, and you put like a drop of Moxie, and then to fill the rest up with like Gentile gel, and then you can kind of get it on their eye, and that way the gel will somewhat be in the scleral lens when you evert the lens onto their eye. And so it protects their eye from exposure. And so it works really, really well. The moxifloxacin is in there to help prevent infection. It is a lot of work for the consult resident and on-call resident if you're doing it. So let me know if this is being considered. I can walk you through it, but there's a whole protocol on box. I don't think we've really used it too often, but just know that this is an option.
I was gonna say, how long should we leave it in there?
So you have to change it every day.
Every day.
Every day, and you have to disinfect it every day, and that's why it's a lot of work. But it like really works. You can save someone from corneal perforation, so it's like totally worth it, but it's a lot of work. Yeah.
How do you feel about steroids, like right at the beginning if somebody does have a chemical or thermal?
I think they're really helpful. Really helpful. So even with in the setting, they usually have like epithelial defects. It's really helpful in the first week, even with active like epithelial breakdown. It helps with inflammation.
And how do you think about somebody's risk of like symblepharon from, I guess I haven't thought about, I think of mostly cornea, but of course if somebody has like, what signs would you look for us to be like, oh no, this person is at risk for maybe like symblepharon formation that we should be following?
If they've got like conjunctival defects
Okay.
that aren't healing, might be, and they're like really inflamed. Yeah. I'm not going to have a whole lot of time to go over SJS, unfortunately, but I do want to definitely mention that if you do see it and you see severe ocular involvement, which I'm going to put this up, they should have urgent amniotic membrane sutured in the OR. So this is maybe on box, but so this is the kind of the criteria for severe involvement. So if there's staining of the lid margin of greater than 1/3 on at least one lid, or any epithelial defect that's more than punctate staining and/or conjunctival staining greater than 1 centimeter, then it's going to be urgent amniotic membrane transplant. So if you ever see that, let our cornea fellows know, and we recommend suturing amniotic membrane, which I don't have a picture of that, but anyway, that's something that's going to be really important. It comes up a handful of times a year. These are just some pictures of SJS patients. This patient did not get amniotic membrane. She probably should have, but she ended up with kind of this keratinization of the lid margin here, which this is the same patient. Like when you look at them initially, like at the slit lamp, like doesn't look that bad, but when you pull their eyelid down, you see this keratinization. And so this patient had like was just kind of severely photophobic, always in pain. You can see I think she ended up with, I think I was just treating her with soft contact lenses at the time, so she's got her contact lens in. This is a patient who had amniotic membrane. She was a young patient, and this is her like a month or two later, and you can like, she looks normal, like eyelashes normal, nice healthy meibomian glands that you see here. The only sign that she had anything done, she's got a tiny little suture in her fornix, so she had eye surgery, but she looks great. This is another young patient who also did not have amniotic membrane until I think much later, but this was maybe a month or two after his initial SJS, but he just had like severe inflammation, lots of tarsal conjunctival scarring, so very kind of a poorer prognosis for this patient. So that's why amniotic membrane is indicated to prevent the bad complications. That's it, yeah.
How do you feel about amniotic membrane versus procarat and like rime patients?
Yeah, so rhyme, I forget what that stands for. It's like, it's sort of like SJS, but it's not as bad. And I have one patient that I'm seeing with rhyme, like right now, who had it like a couple months ago. I don't think I've ever done like, maybe once was like a full amniotic membrane.